we talk about the pathophysiology of infective endocarditis. Next slide. But infective endocarditis typically occur at the site of pre-existing endocardial damage, but sometimes may occur even virulent or aggressive microorganism may cause endocarditis in the previously normal heart. So it's usually and typically occur in pre-existing endocardial damage, but if the microorganism is virulent, for example, Staphylococcus aureus, can occur in endocarditis with a previously normal heart. Pre-existing endocardial damage occur in many acquired and congenital cardiac lesions, particularly arrays of endocardial damage caused by high pressure jet of the blood. In these cases, the avascular valve tissue and the presence of fibrin platelet aggregate to help protect proliferating organism from host defense mechanism, and so vegetations will occur and be composed of organism and fibrin and the platelet that grow and may become large enough to cause obstruction or systemic embolization. Other extracardiac manifestations other than the cardiac manifestation include vasculitis and skin lesion are due to embolic or immune complex deposition. What about the microbiology? Which microorganism will cause the infection of the endocardium or infective endocarditis? Next slide. Over 3/4 of cases are caused by Streptococcus or Staphylococcus. And in some cases of some patients with large bowel obstruction, with large bowel neoplasm, there is specific microorganism which is Streptococcus bovis and Streptococcus miliarii. But Staphylococcus aureus has now overtaken Streptococci as the most common cause of acute endocarditis. Previously, the most common cause of infective endocarditis are by Streptococci. But now, the most common cause is Staphylococcus aureus. Postoperative endocarditis occur due to coagulase-negative Staphylococcus aureus, or between two brackets Staphylococcus epidermidis. So, if we have a patient develop infective endocarditis in the postoperative period, the most common cause is Staphylococcus epidermidis. Other specific form of endocarditis is Q fever endocarditis caused by Coxiella burnetii, especially in farmer, and other slow-growing fastidious organisms are the HASIC and are only discovered after prolonged culture and may be resistant to penicillin. Other form of endocarditis is caused by Brucella and yeast and fungi, especially Candida and Aspergillus. Next slide. This is a table showing that the pathogen and the percent of involvement in the naive or IV drug users or oropathic. Next slide. Incidence. The infective endocarditis occur in 5 to 15% of cases. In 5 to 15%. In 5 to 15 cases per 100,000 per annum of population per annum. 50% of patients are over 50 years, 60 years, and 24% have rheumatic heart disease, and 19% of patients having congenital heart disease, and 25% of cases having calcified aortic or floppy mitral valve, and 32% were not thought to have a pre-existing cardiac abnormality. And these 32% of cases are mostly caused by Staphylococcus virulent microorganism. Clinical feature. How the patient present. We have 3 forms, either subacute endocarditis or acute endocarditis or postoperative endocarditis. And a clinical manifestation range from cardiac to extracardiac and systemic manifestation. Cardiac manifestation include, first of all, are varying murmur, or a new murmur, conduction, heart disorder, and cardiac failure. This is for the cardiac manifestation. So, how we discover the infective endocarditis? By either developing of new cardiac murmur and a patient who have a pre-existing murmur, or patient develop sign and symptom of heart failure in the presence of systemic manifestation. For example, fever, fatigue, cerebral emboli, rough spots in fundi, petechial hemorrhages in the mucous membrane and the skin, splenomegaly, systemic emboli, nail fold and pharynx, digital clubbing, splinter hemorrhage, and conjunctival hemorrhage, and ocular node and petechial rash. This is the manifestation of infective endocarditis. How we diagnose it? We diagnose it by using specific criteria. It's called modified Duke criteria. Next slide. Modified Duke criteria. We have major criteria and minor criteria. For the major criteria, we have to withdraw blood culture. Positive blood culture include typical organism from 2 cultures, or persistent positive blood culture taking more than 12 hours apart, or 3 or more positive blood culture over 1 hour, plus evidence of endocardial involvement from a positive echocardiographic study of vegetation or a new valve regurgitation. While the minor criteria, we had either predisposing valvular or cardiac abnormality, intravenous drug misuse, pyrexia more than 38 centigrade, embolic and vasculitic phenomena, blood culture suggestive of organism growing but not achieving major criteria. The major criteria require typical organism from 2 culture, persistent positive blood culture taken 12 hours apart, or 3 or more positive culture taken over 1 hour, plus suggestive echocardiographic finding. For definite diagnosis of infective endocarditis require 2 major criteria, or 1 major criteria and 3 minor, or 5 minor criteria. For possible endocarditis require 1 major criteria and 1 minor criteria, or 3 minor criteria. What investigation required? Obviously, next slide. Obviously, blood culture, the gold standard investigation in patients with infective endocarditis. Second, the blood culture should be taking at least 2 to 3 blood culture. Echocardiography to demonstrate vegetation or a new valve regurgitation. ESR, C-reactive protein, CBC for evidence of systemic involvement. ECG for evidence of heart block. Chest X-ray for any cardiomegaly. Management of the patient. The case fatality for bacterial endocarditis is approximately 20%, so it is high case fatality. It requires multidisciplinary approach, and we have empirical treatment. Why empirical treatment? Because the blood culture requires a time to become available, and so when the first we suspect infective endocarditis, we have to start empirical treatment. Empirical without knowing the exact microorganism. Empirical treatment depends on the mode of presentation and the suspected microorganism, and whether the patient has a prosthetic valve or penicillin allergy. If the presentation is acute and Staphylococcus aureus is suspected, flucloxacillin and gentamicin are recommended, while for subacute or more chronic presentation, benzyl penicillin and gentamicin are preferred because Streptococcus is suspected. In those with penicillin allergy, we use vancomycin, gentamicin, and oral rifampicin. So this treatment is continued until the result of blood culture become available. And when the result of a blood culture become available, we switch according to the blood culture and sensitivity. 2-week treatment regime may be sufficient for fully sensitive strain, but may be extended even to 4 to 6 weeks if more aggressive or more virulent microorganism. Next slide. In this condition, we use the short course of treatment, which is 2 weeks rather than 4 to 6 weeks. In case of native valve infection, native is mean no prosthetic valve. Minimum inhibitory concentration less than 0.1 milligram per liter. No evidence of poor prognostic factor. No evidence of thromboembolic disease, and no vegetation more than 5 millimeter in diameter, and clinical response within 7 days. That is, the patient become afebrile within 7 days. In this case, the duration of antibiotic use is only 2 weeks. But when these conditions are not met, we use a prolonged course of antibiotics more than 4 to 6 weeks. Next slide. In this slide, when the result of a blood culture become available, we switch according to the antibiotic according to blood culture and sensitivity. Next slide. So sometimes there is indication of surgery in patients with infective endocarditis, which is the indication of cardiac surgery in patients who have infective endocarditis. First of all, development of heart failure, it means valve damage, an indication for valve replacement, or failure of antibiotic therapy. It indicates persistent or uncontrolled infection and required decompression and cleaning by surgery. Large vegetation on the left side of the heart valve with evidence of high risk of systemic emboli. In this case, should be removed. The large vegetation should be removed surgically because of risk of systemic embolization and in case of abscess formation. Not by patients with a prosthetic endocarditis or fungal endocarditis often require cardiac surgery. Next slide. Now we change to a new subject, which is the congenital heart disease. The importance of the important thing to understand congenital heart disease is to understand fetal circulation. In fetal circulation, it is important to know that the fetal circulation is different from adult circulation. What is the difference between fetal and adult circulation? Is that in the adult, the patent foramen ovale will be closed immediately or shortly after the birth. Patent foramen ovale, which is present in between the atria and allow the passage of the blood from the right atrium to the left atrium in the fetal life. The second most important change between the adult and fetal circulation is the patent ductus arteriosus. In the children in the fetal life, there is a ductus arteriosus that connects the pulmonary artery to the descending aorta, and while at the birth this should be closed immediately. In the fetal circulation, the blood comes from the umbilical vein. The oxygenated blood comes from the umbilical vein to enter the inferior vena cava and then the right atrium, and most of the oxygenated blood in the right atrium will go to the left atrium through the patent foramen ovale. From the left atrium, the oxygenated blood go to the left ventricle, and from the left ventricle will go to the ascending aorta, and then to the head and neck vessels. And after bypassing the aortic isthmus, it will go through the ductus arteriosus. From the ductus arteriosus will go to the pulmonary artery, and from the lung will return through the superior vena cava to enter the right atrium. Okay, other part of the blood from the descending aorta will go to the abdominal organ, and after leaving the iliac artery and after the iliac bifurcation, the blood return from the umbilical arteries to enter the blood circulation of the mother. So the important difference is that the patent foramen ovale and ductus arteriosus. The benefit of patent foramen ovale is for the oxygenated blood from the right atrium that come from the mother to go to the left atrium and then to the systemic circulation. The importance of ductus arteriosus is to allow the blood to bypass the lung and enter the descending aorta. Okay, this is too important for changes from the fetal circulation to adult circulation. So what is the benefit of ductus arteriosus? Is for the deoxygenated blood in the right ventricle after passing into the common carotid arteries. It cannot go to the lung of the fetus because the lung of fetus is immature. So most of the blood will go through the ductus arteriosus into the systemic circulation, and after admixed with the blood returned from the inferior or descending aorta, it goes through the umbilical arteries and then go to the veins of the mother in order to be oxygenated again. Next slide.
العفو دكتور، ولو أقاطعكم بس هذه الأيورتيك اسمس هو هذا السايت Coarctation of aorta وشنو فائدته بالفيتال circulation؟
Aortic isthmus it is the site of development of coarctation of aorta if occurred. Usually aortic isthmus is a landmark, have no specific benefit in the fetal circulation. لكن the most important is the ductus arteriosus. Okay?
تمام دكتور، شكرا.
Aortic isthmus is a landmark. Landmark of what? Of development, first of all, of two important landmarks. Distal to the aortic isthmus, there is the insertion of the ductus arteriosus in the fetal circulation, and distal to aortic isthmus is the landmark of occurrence of coarctation of aorta if occurred later in life. Okay?
Okay دكتور، عشت لكم.
Other important significance of aortic isthmus in pathophysiological significance. It may be a site of development of infective endocarditis later on. Okay, next slide. The incidence of congenital heart disease about 0.8% of live birth, and may be associated with rubella, alcohol, HLE, or a drug and toxin taken by the mother. May be associated with congenital or chromosomal abnormalities such as Down syndrome or Marfan syndrome. And the most common congenital heart disease are VSD or ventricular septal defect, occur in 30% of cases. Second most important is ASD, which occur in 10% of cases, and patent ductus arteriosus, which occur in 10%. Other less common lesions are pulmonary stenosis, coarctation of aorta, congenital aortic stenosis, Tetralogy of Fallot, complete transposition of great arteries. Next slide. Clinical feature. The most important clinical signs vary by the anatomical lesion, and symptom may be absent, or the child may be breathless, or fail to attain normal growth and development. Some defects are not compatible with the life. Feature of other congenital conditions such as Marfan syndrome or Down syndrome may be present. And early diagnosis is important because many types of congenital heart disease are amenable for corrective surgery. Next slide. Also may be present with central cyanosis and digital clubbing as we said, may present with growth retardation or learning difficulties, and sometimes with syncope, and sometimes present with feature of pulmonary hypertension and Eisenmenger syndrome. What about the association of pregnancy and congenital heart disease? Next slide. Pregnancy is not advised in patients with severe aortic stenosis and in patients who have pulmonary hypertension and Eisenmenger syndrome. Also, while if the congenital heart disease lesion is surgically corrected, the patient often tolerates pregnancy well. Children of patients with congenital heart disease have 2 to 5% risk of being born with cardiac abnormality if the mother is affected. Now we talk about the patent ductus arteriosus. Next slide. Patent ductus arteriosus, when ductus arteriosus fails to close after the fetal life. So the blood, so the blood will pass from the aorta to the pulmonary trunk, and from the pulmonary trunk to the postpulmonary arteries and lung, and then return to left atrium to be pumped again through the left ventricle to the ascending aorta, and then enter again pulmonary artery through the ductus. And this is termed the recirculation of the blood through the left ventricle and the lung without being passed to the systemic circulation. So, other important difference here in the passage of the blood. Here in the adult life, the blood passes from the aorta to the pulmonary artery because the aortic pressure is more than the pulmonary artery pressure. While in the fetal life, the blood passes from the pulmonary artery to the aorta, and not vice versa, because the pressure in the pulmonary artery more than the pressure in the ascending in the aorta in the fetal life. Next slide. So as we said, we have 50% of the left ventricle output is recirculated through the lung because of the ductus, and normally it should be the ductus should be closed soon after the birth, but if sometimes fail to do so, result in patent ductus arteriosus. Clinical feature, next slide. Small shunt may be asymptomatic for years. When the ductus is large, growth and development may be retarded, and presentation with cardiac failure may ensue, with dyspnea being the first symptom. On auscultation, we have continuous machinery murmur and continuous machinery murmur can be heard, which indicate persistent ductus arteriosus. Sometimes, with the development of Eisenmenger syndrome or pulmonary hypertension, there will be reversal of the shunt, so that between two brackets return to fetal life, and their blood will be shunted from the pulmonary artery to the systemic circulation. Because of the blood in the pulmonary artery is deoxygenated, so the patient will become cyanosed. Management, next slide. A patent ductus is closed at cardiac catheterization with implantable occlusive device. Sometimes there is pharmacological treatment that is indicated only in the neonatal period, in the first few days of life, with the use of prostaglandin synthetase inhibitor, indomethacin, or ibuprofen. Next slide. We talk about the second subject, which is the coarctation of aorta. Coarctation of aorta, it occur in the region where the ductus arteriosus join the aorta. اللي سأل عليها زميلكم اللي هي الاسمس. Occur at the region where the ductus arteriosus join the aorta that is the isthmus, just below the origin of left subclavian artery. Twice as common in male occur in 1 to 4,000 children, associated with other abnormalities, most frequently bicuspid aortic valve and perianeurysm of cerebral circulation. Acquired coarctation of aorta is rare, but may occur following trauma or occur as a complication of progressive arthritis, that is Takayasu disease. Clinical feature, next slide. Coarctation is an important cause of cardiac failure in the newborn. We have two modes of clinical presentation of coarctation of aorta. First, if present in the newborn, it is present with cardiac failure. But if coarctation of aorta is mild and present in the adult life, it is present with headache, weakness, cramps in the leg, and differential hypertension. What is the differential hypertension? That is hypertension in the upper part of the body and normal blood pressure in the lower, or hypotension in the lower part of the body. With radiofemoral delay, systolic member may be heard posteriorly or in the aortic area with ejection click due to bicuspid aortic valve. On investigation, on chest X-ray, we have reverse 3 sign and rib notching because of development of collateral circulation. On ECG, we have left ventricular hypertrophy. Why? Because coarctation of aorta behave like left ventricular outflow obstruction, and for left ventricle we need a the left ventricle will contract against a pressure. This is pressure because of coarctation. Coarctation means stenosis in the aorta. So the left ventricle will contract forcibly, and this leads to remodeling and left ventricular hypertrophy. Echocardiography may confirm the diagnosis, and the best imaging modality to confirm the diagnosis is the MRI. Next slide, we see the reverse 3 sign by aortogram, and we see excessive collateral circulation radiating in between the rib and may cause rib notching. Management: surgical correction is advisable in most cases. So this condition almost always needs surgical correction. Patient repaired later in childhood or adult life often remain hypertensive or develop recurrent hypertension. A recurrence of stenosis is amenable for balloon dilation. Coexistent aortic valve may occur in 50% of cases and lead to progressive aortic stenosis regurgitation and may require long-term follow-up. Next slide, we talk about the atrial septal defect. Atrial septal defect is one of the second most common cause of congenital heart defect, occur twice in female, and most are ostium secundum defects. For the atrial septal defect, we have several types. We have ostium secundum defect, ostium primum defect. Ostium primum defect results from defect in the atrioventricular septum and are associated with the cleft mitral valve, split anterior leaflet, while the ostium secundum occur in the muscular portion. As we know anatomically, the atrial septum has muscular portion and membranous portion. If the defect occur in the muscular portion, it's called ostium secundum. If the defect occur in the membranous portion, it is called ostium primum, which is near the base or inferior portion of the atrial septum and occur nearby the mitral valve and associated with the cleft mitral valve. So the patient will have ASD and defect in the mitral valve in the case of ostium primum. In long-standing cases, when the atrial septum defects occur for a long time and we have significant a shunt of the blood from the right side to the left side. Later on, the pulmonary hypertension will develop and the shunt will be reversed. What is the shunt reversal in ASD? As I told previously, usually the shunt in ASD occur from the left side of the heart to the right side because the left atrium have more or higher pressure than the right atrium. So the blood will pass from through the atrial septal defect from the left atrium to the right atrium. Over a long time, there will be development of high pulmonary blood pressure. And when pulmonary hypertension develops, there will be shunt reversal, and the deoxygenated blood will pass from the right atrium to the left atrium. And development of pulmonary hypertension is called as a Menger syndrome, and heralded by the development of cyanosis in patients who have ASD. Next slide. It is the clinical feature. Clinical feature usually asymptomatic if early in life, or if the defect is small. Sometimes we have dyspnea due to shunt of the blood. Sometimes we have recurrent chest infection due to pulmonary hyperemia or increased blood flow through the lung due to shunt. Sometimes we have heart failure, arrhythmia, AF, and later on development of pulmonary hypertension and Menger syndrome. Development of pulmonary hypertension is known by when the patient become more dyspneic and cyanosed. Signs on examination of ASD: wide fixed splitting of second heart sound. We may hear a systolic flow murmur due to flow of the blood through the pulmonary valve, overflow of the blood, increased flow of the blood through the pulmonary valve, or even we have diastolic flow murmur due to increased flow of the blood through the tricuspid valve. Investigation. Next slide.
العفو دكتور، ولو أقاطعكم تقدر دكتور الوايد فيكس سبليتنج تعطينا الميكانيزم مالتها لأن شوية صعبة صارت بالمرمر.
The wide fixed splitting of second heart sound. Normally, we hear a splitting of second heart sound. Why we hear splitting of second heart sound? Because there is some delay because of difference in the pressure of the left ventricular outflow and the right ventricular outflow. So there will be the second heart sound. There will be splitting of second heart sound, and this splitting of second heart sound occur. This fixed splitting of second heart sound, we have either fixed or variable. During the inspiration, when we have taken an inspiration, there will be an increase in the blood flow through the lung because of increased air in the lung. So there will be delay in the closure of the pulmonary valve in comparison with the aortic valve, and the closure of pulmonary aortic valve will give us the second heart sound. Okay, during the inspiration we have delayed splitting of second heart sound. One of the other causes that cause fixed splitting of second heart sound, that is splitting of S2 during the inspiration and during the expiration, is the ASD. Why? Because the ASD allow more blood to enter the right ventricle through the right atrium, and so the right ventricular emptying will increase, and the blood flow will increase. This increase in the blood flow will cause delay in the right ventricular outflow and will cause fixed splitting and wide and fixed splitting. Fixed mean even in the inspiration and expiration. wide يعني exaggerated mean exaggerated. اوكي
تمام دكتور عشتيتهم. بس دكتور الايورتيك فالف ما له علاقة بالوايت سبليتنج، يعني ما يأثر عليها على duration مال الكلوجر؟
الايورتيك valve قلنا هي difference between the aortic valve and pulmonary valve closure.
نعم.
Why the pulmonary valve closure is NASD become fixed and wide? Because of an increase in the blood flow through because of a shunt of the blood from the left atrium to the right atrium. So there will be an increase in the amount of the blood in the right atrium go to right ventricle, and an increase in the amount of the blood pumped out from the right ventricle through the pulmonary valve. So an increase in the blood flow and in the pulmonary valve related to the aortic valve.
عشتيتكم دكتور.
Next slide. Investigation. We have ECG which demonstrate. Next slide. ECG will demonstrate right bundle branch block, right axis division, and in case of primum defect, left axis division. Chest X-ray may show pulmonary plethora, cardiomegaly, and a prominent pulmonary artery. Next slide. Next slide. So chest X-ray will show cardiomegaly, pulmonary plethora. On echocardiography, when we do echo for the patient, it is the gold standard for diagnosis and show the defect in the atrial septum and define the right ventricular and pulmonary artery dilation. And finally, we have transesophageal echocardiography. It is the most appropriate investigation to allow better anatomical visualization of the defect and the size of the defect and a plan for therapy. Next slide. This is an transesophageal echocardiography showing the shunt of the blood through the septum. Management. How we manage a case of atrial septal defect. Atrial septal defect.
طلعتكم اليوم بس اللي transesophageal نعتبره هو الجولدن ستاندرد ولا الإيكو؟
الجولد ستاندرد diagnosis هو الإيكوكارديوغرافي والترانسesophageal echocardiography. It is a form of echocardiography.
تمام.
فاحنا نستخدم الترانسesophageal echocardiography as a pre-operative assessment على مود يحدد لنا السايز مال الاوكلوزيف ديفايس، يد الحجم، most appropriate diagnosis, most appropriate size، وثانيا to exclude any thrombus or any associated valve abnormality. Okay. فالجولد ستاندرد diagnosis هو simple echocardiography. لكن الترانسesophageal echocardiography to plan for surgery or to plan for treatment. Pulmonary plethora هي increase the blood flow through the pulmonary vessels. شو مدى يطلع ما تتحول. Next slide please.
دكتور هسه السلايد مال الترانسesophageal واضح يمكم؟
لا هسه على clinical feature.
لا دكتور أنا وصلت تمام هسه بس طبعا خلي أشوف مشكلة.
So, the management of the patient with atrial septal defect is atrial septal defect in which pulmonary flow is increased by 50% above the systemic flow are often large enough to be clinically recognizable and should be closed. So, it is closed either by cath or by surgery. Severe pulmonary hypertension and shunt reversal are both contraindication for surgery. احنا قلنا atrial septal defect should be corrected by surgery، لكن هذا corrective surgery contraindicated لما اكو severe pulmonary hypertension واكو shunt reversal، يعني development of Eisenmenger syndrome. Eisenmenger syndrome شنو يعني؟ هو development of pulmonary hypertension that lead to shunt reversal. هذا contraindication for correction. Next slide. هذا السلايد راح يشوف لنا occlusive device in place for correction of atrial septal defect. Next slide. هسه الموضوع الثاني راح نحكي عنه هو ventricular septal defect. It is either congenital or acquired, and most congenital defects are perimembranous. مثل ما نعرف احنا ال VSD بها two portion، بها membranous و muscular. الممبرينس صاير بالجزء العلوي عكس ال ASD. الممبرينس portion هو بالجزء العلوي، بينما ال ASD الممبرينس portion هو الجزء السفلي. ال VSD ال VS ventricular septal membranous portion هو الجزء العلوي من عندها most superior portion. وال most congenital defect here are perimembranous, and most common congenital VSD is the most congenital cardiac defect occurring once in 500 live births. Acquired VSD may result from rupture as a complication of acute MI or from trauma. Clinical feature usually present with pan-systolic murmur, usually hit best at the left sternal edge, but radiating all over the precordium. Sometimes we have a small defect producing a loud murmur in the absence of other hemodynamic disturbance. In this condition, it is called maladrogeia. Congenital ventricular septal defect may present as cardiac failure in infant if the VSD is very large, and sometimes there is multiple. May present as a cardiac failure in infant, or may present finally with Eisenmenger syndrome if it is neglected and present later in adult life. May present as Eisenmenger syndrome when reversal of the shunt occur and the patient presents with pulmonary hypertension. If cardiac failure complicates a large defect, it only becomes apparent in the first 4 to 6 weeks of life. The chest X-ray show pulmonary plethora. Pulmonary plethora mean an increased blood flow to pulmonary vessels. And ECG show bilateral ventricular hypertrophy. Echocardiography is called the standard for diagnosis. Management, how we manage it? Small VSD require no specific treatment اللي هي هاي نسميها المالاديراجيا، بينما large VSD should be treated medically by digoxin and diuretic, and persisting failure is an indication for closure of defect by cath or surgery. Except in Eisenmenger syndrome, long-term prognosis is very good in congenital VSD. So, in summary, VSD, how we can manage it? Small defect, there is no hemodynamic compromise, no increased blood flow in the lung, require no treatment and even no surgery. While symptomatic patients who have moderate defect require treatment with digoxin and diuretic. And if the pulmonary blood flow in comparison to the systemic blood flow is increased but not reach the stage of pulmonary hypertension, here the indication of surgery, indication of correction by surgery. If the patient develops pulmonary hypertension, it is contraindication for surgery, only medical treatment. Next slide. Now we talk about Tetralogy of Fallot. It is one of the cyanotic congenital heart disease. هسه احنا قبل شوية حكينا على ال ASD, PDA, Coarctation of aorta, VSD, ASD، ذني كلهن يسموها acyanotic. Acyanotic يعني present without cyanosis initially. Acyanotic congenital heart disease. لكن هسه راح نبدي نحكي على ال cyanotic congenital heart disease اللي هي congenital heart disease present initially with cyanosis. Tetralogy of Fallot مثل الاسم مبين تترا يعني تتكون من 4 أمور 4 finding. أول finding هو pulmonary stenosis. pulmonary stenosis ممكن valvular ممكن supravalvular. ثانيا overriding of aorta يعني الأيورتا صاير فوق ال VSD فوق ال ventricular septum. override يعني the aorta override the ventricular septum. 3 ventricular septal defect. 4 right ventricular hypertrophy. right ventricular hypertrophy ليش يصير؟ لأنه أكو pulmonary stenosis. Next slide. Aetiology. Embryological cause is abnormal development of bulbar septum that separate the ascending aorta from the pulmonary artery. يعني maldevelopment. The defect occur about 1 to 2 to 1 in 2000 birth and is the most common cause of cyanosis in infancy after the first year of life. Clinical feature. شلون يجي المريض؟ Children are usually cyanosed. يعني هي cyanotic congenital heart disease. Second presentation is Fallot spills. Fallot spills شنو؟ انه الطفل لما يسوي exertion راح يصير عنده shortness of breath. ولما يصير عنده shortness of breath راح يسوي Fallot sign. شنو الفالوت sign؟ obtain relief by squatting after exertion. هذول شلون يقول لك يجونا؟ دكتور ابني لما يلعب ويا الاطفال احسه مثل يقول لي ماما اختنق اقوم اختنق وش يسوي؟ يقوم يدنق او يتربع او يقعد او يسوي سكواتنج. سكواتنج هي جلسة القرفصاء او يسوي سكواتنج على مود نفسه يستحسن عليه والخنقة تروح من عنده. هذه يسموها فالوت سبول. On examination cyanosis, loud ejection systolic murmur in the pulmonary area due to pulmonary stenosis. Cyanosis may be absent in the newborn or in patients with only mild right ventricular outflow obstruction. Sometimes إذا المريض ما عنده significant pulmonary stenosis not present with cyanosis. Investigation. Next slide. ECG راح يشوف لنا right ventricular evidence of right ventricular hypertrophy. chest X-ray راح نشوف فيه boot shaped heart. الإيكو confirms the diagnosis. The definitive management is total surgical correction. إذا pulmonary arteries is too hypoplastic, sometimes we have hypoplastic pulmonary artery يعني essentially not present, then palliation in the form of Balaluk-Tusing shunt. The prognosis after total correction is good. ICD sometimes recommended in adulthood. Next slide.
العفو دكتور بس شنو ICD؟
ICD implant مو حكيناها بالهارت فيلير وحكيناها بالاريثميا. implantable cardioverter defibrillator.
تمام شكرا.
Next slide. Next slide. منتظر.
نعم دكتور التيبل ما طلع يمكم؟ التيبل؟
لا. لا القبلة. منتظر.
نعم دكتور هو بس شوي تأخر يلا يفهمكم.
هذا السلايد. next slide هو ال other causes of cyanotic congenital heart disease. عندنا ال tricuspid atresia, transposition of great vessels, ال pulmonary atresia and Epstein abnormally. هذني very rare and present with cyanosis and present especially in the early newborn or childhood period with cyanosis. Next slide. Next slide. بلالوكتاوسينج الشنت. هي البلالوكتاوسينج الشنت هي عبارة عن alleviation of pulmonary hypertension. نسوي redirection of the blood. ناخذ البلاد نسوي له redirection from the from subclavian artery ونربطه للرايت or left pulmonary artery. هذا يسموه بلالوكتاوسينج. الفكرة مالته على مود تقلل البلمونري hypertension، تقلل البريشر على البلمونري arteries. next slide. next هسه نحن نحكي عن rheumatic heart disease. next slide. rheumatic heart disease عندنا نقسمها إلى acute rheumatic fever و chronic rheumatic heart disease. acute rheumatic fever هو a disease of childhood and adolescent, present in children and young adults 5 to 15 years of age, and rare in high-income countries and more endemic in India, Africa, South Africa, and previously we see this disease in our society also, but now it's less common. Triggered by autoimmune-mediated phenomena, delayed response to infection with a specific strain of group A streptococci, which have antigen that may cross-react with cardiac myosin and sacrolimal membrane protein. Histologically, fibrinoid degeneration is seen in the collagen of connective tissue, and Ashok nodules are pathognomonic and occur only in the heart. شنو هذا الروماتيك فيبر؟ روماتيك فيبر دلوقتي يصير infection بالتونسل or of the child، لكن وهذا infection بالتونسل by group A streptococci راح يصير immunity against this group A streptococci، لكن هاي الاميونيتي يصير misunderstanding بيها للجسم، يقوم يفسر self tissue as antigen of bacteria or antigen of foreign, and so the immunity will attack self tissue. من هي هاي self tissue اللي هي will be attacked by immunity؟ هي cardiac myosin and sacrolimal membrane protein. okay، فراح يصير inflammation around the cardiac myosin and sacrolimal membrane protein. هذا الانفلاميشن lead to fibrinoid degeneration وكولاجين deposition واشوف nodule formation. بالتالي لما يصير inflammation بالهارت راح يصير impairment للورك مال الهارت. شلون present clinical feature. Next slide. Clinical feature is the multisystemic disorder present with fever, anorexia, lethargy, and joint pain 2 to 3 weeks after an episode of streptococcal pharyngitis. يعني ورا اسبوع الى اسبوعين الى 3 لما يصير tonsil او pharyngitis عند الchild راح يبدي يصير عنده joint pain, fever, anorexia, lethargy, and 25% of patients will have positive blood culture for group A streptococci. Sometimes we have serological evidence of recent infection with raised ASO titer. A presumptive diagnosis of acute rheumatic fever can be made without evidence of preexisting streptococcal infection in case of isolated chorea, endocarditis, if other causes of these have been excluded. The diagnosis is made using revised Jones criteria. Next slide. Revised Jones criteria, we have major and minor manifestation. Major manifestation include carditis, Major manifestation include carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodule. Minor manifestation include fever, arthralgia, previous rheumatic fever, raised ESR or C-reactive protein, leukocytosis, and first-degree AV block. هاي criteria يحتاج لنا supporting evidence of preceding streptococcal infection. شنو هو supportive evidence of preceding streptococcal infection، مثلا يعطينا هيستوري انه صار عنده سكارلت فيفر، او نسوي له انفستيجيشن نشوف الاي اس او تايتر اللي هو انتي ستريبتولايسين او تايتر ريز، او نسوي له streptococcal antibody titer ونلقاه ريز، او نسوي له positive throat culture. هذول يسموها supportive evidence of streptococcal infection. اوكي، فالميجر manifestation هي carditis, polyarthritis, chorea, erythema marginatum and subcutaneous nodule. Next slide. الكاردايتس شلون يجي المريض نقول عنده كاردايتس؟ الكاردايتس ممكن تكون بانكاردايتس يعني مايوكاردايتس، بيريكاردايتس، اندوكاردايتس، او ممكن يكون بس بيريكاردايتس. المانيفستيشن مالت الكاردايتس هو heart failure, shortness of breath, palpitation, chest pain, tachycardia, new murmur اللي هي either systolic or diastolic. Cary-Coombs murmur هي mid diastolic murmur due to mitral stenosis that occur in patients with acute rheumatic fever. وكذلك ممكن diastolic murmur of aortic regurgitation in 50% of cases. Pericarditis ممكن يصير عند المريض، وممكن يصير عنده ECG changes with STT wave changes and conduction cardiac defect. هاي carditis. The second important manifestation, next slide, here arthritis. Arthritis is the most common major manifestation, occur in 75% of cases, and occur early with painful, asymmetric, and migratory inflammation of large joints, typically affect the knees, ankle, elbow, and wrist, and occur with pain and joint swelling. Characteristically respond to aspirin. If not respond to aspirin, the diagnosis is in doubt. Next manifestation is the skin lesion. Next slide. We have erythema marginatum that occur in less than 5% of cases, and subcutaneous nodule that occur in 5 to 7% of cases. Other systemic manifestations are rare but may include pleurisy, pleural effusion, and pneumonia. And finally, next slide, Sydenham chorea. Sydenham chorea is the latest آخر manifestation تطلع هي الكوريا. Late neurological manifestation appear at least 3 months after the episode of acute rheumatic fever in 1/3 of cases, and most common in female, and with spontaneous recovery usually occur within a few months, and 1/4 of the affected patient will go on to develop chronic rheumatic valve disease. Investigation. Next slide. مثل ما حكينا بالكرايتيريا، الانفستيجيشن يحتاج نسوي له اليوكوسايت كاونت، يحتاج نسوي لنا ESR selective protein، ASO titer, culture, throat swab culture على مود نشوف جروب A بيتا هيموتيك ستروكوكاي، ASO titer rising titer أكثر من 200 بالأدلت وأكثر من 300 بالchildren indicate evidence of preceding streptococcal infection. Evidence of carditis شلون راح نعرفها؟ من الهيستوري والاكزامينيشن ومن الchest x-ray. الchest x-ray راح نشوف لنا cardiomegaly, pulmonary congestion, ECG first and sometimes second degree AV block, T-wave inversion, reduction in equivalent voltage, echocardiography راح نشوف لنا dilation of the heart and valve abnormalities. The management of acute attack. Next slide. Single dose of benzylpenicillin 1.2 million unit IM, deep IM, or oral phenoxymethylpenicillin 250 milligram 4 times a day for 10 days to clear streptococci. Second, bed rest and supportive therapy. Supportive therapy indicates if the patient have dehydration, increase hydration. If the patient have heart failure, we treat him with diuretic and digoxin. If the patient have palpitation, we treat with palpitation. If the patient have heart block, treat the heart block. This is the supportive therapy. Aspirin, large dose of aspirin may reach up to 1 gram 1/4. Corticosteroid indicated for development of heart failure. If the patient develop heart failure, we use corticosteroid therapy. Secondary prevention. Next slide. Sometimes we need to secondary prevention. That is, if the patient have episode of acute rheumatic fever, he is at risk of development of recurrent attack of rheumatic fever in the future. Further attack of rheumatic fever are unusual after the age of 21. So, secondary prevention until in those with residual heart disease, secondary prevention indicated for the patient with residual heart disease يعني عنده valve lesion أو عنده VSD أو عنده ASD أو عنده any structural heart disease وعنده episode مال infective endocarditis أو عنده episode مال rheumatic fever. هذا المريض اللي عنده valve disease وصاير عنده من قبل infective endocarditis عنده infective endocarditis. هذا المريض ايش نسوي له؟ نعطيه secondary prevention strategy. ايش وقت نعطيه اياه؟ 10 سنوات after the last episode or الى ان يصير or 40 years of age الى ان يصير عمره 40 سنة. Long term prophylaxis with penicillin should be given as benzathine penicillin 1.2 million unit IM monthly if the compliance is not good. Or if he is compliant, oral methoxypenicillin 250 mg twice daily. Sometimes sulfadiazine or erythromycin if he is allergic to penicillin. And finally, last slide, we have a chronic rheumatic heart disease. Sometimes episode of acute rheumatic fever will leave as a structural defect within the heart valve. This structural defect in the heart valve is called chronic rheumatic heart disease. It develops in at least half of those affected by acute rheumatic fever with carditis. 2/3 of cases occur in women. It is only possible to elicit a history of rheumatic fever or chorea in about half of all patients with chronic rheumatic heart disease. And almost always it affects the mitral valve in more than 90% of cases. As we told in the lecture of valvular heart disease, mitral stenosis is almost always caused by rheumatic heart disease. So, if half of the cases affected by rheumatic fever will develop a residual valve defect in the mitral valve, which is either mitral stenosis or mitral regurgitation. And mostly هو mitral stenosis. And less commonly هي aortic valve stenosis. Most of the time the culprit lesion occur in the mitral valve and will lead to mitral stenosis in the adult life. هسه هسه انتهت المحاضرة مالتنا. إذا اكو اي سؤال؟
عاشتيتكم دكتور. بس عندي سؤال ولو زحمة. إذا شفنا بانسيستوليك مارمر فشون نعرف هذا جاي من mitral regurgitation أو من VSD Tetralogy of Fallot؟ شون الفرق بيناتهم يعني؟
اي هاي البانسيستوليك مارمر عندنا احنا الديفرنشال دايجنوز مال البانسيستوليك مارمر هو 3: VSD MR يعني
نعم
VSD MR والثالث هو TR أو tricuspid regurgitation. شلون الفرق بيناتهم؟ ال VSD تسوي لنا بالبانسيستوليك مارمر بيمن بالليفت سترنال ايج السايت مالتها. أول فرق هو بالسايت بالليفت سترنال ايج and may radiate all over the precordium. يعني شنو هاي الحكاية؟ يعني وين ما تروح بالبريكارديوم تسمع بانسيستوليك مارمر، تروح بالبيس بان بالابكس بان لكن الاريا اوف ماكسيمم انتنسيتي وين؟ بالليفت سترنال ايج. هذا البي اس دي. الام ار راح تسمع البانسيستوليك مارمر بس بالابكس فقط بالابكس وما تسمعها بالبيز مال الهارت. الابكس وين صايره؟ صايره بالفيف انتركوستال سبيس. التي ار راح تسمع بانسيستوليك مارمر بالليفت لور سترنال ايج الماكسيمم انتنسيتي مالتها وراديت للابيجاتريوم. هذا الفرق بيناتهم.
تمام، عشتيكم دكتور. زين دكتور، بالروماتيك فيبر ما نقدر نعتبر التروبونين هو انفستيجيشن باعتبار قاعد يصير دمج للمايوسايت؟
ممكن هو indicator of myocardial necrosis. تروبونين بين قوسين، شنو تروبونين؟ هو indicator of myocardial necrosis. لكن احنا ما جبناه بالطاري هنا لسببين. السبب الاول انه التروبونين مثل الروماتيك هارت ديزيز هي كلاسيكال اولد ديزيز. اساسا قبل لا يكتشف التروبونين كانفستيجيشن فور كاردياك ديزيز كان اكو هذا الديزيز اللي هو الروماتيك هارت ديزيز. ثانيا واكو سمبل انفستيجيشن عندك انت تقدر تعتمد عليها وتقول لك اكو مايوكارديال دامج rather than the troponin. مثل شنو هي simple investigation؟ يعني هي development of valvular rhythm, development of heart failure, development of clinical deterioration بالcondition، الايكوكارديوغرافي، هاي كلها توحي لك انه اكو صاير مايوكارديال دامج. لهذا السبب. لكن ممكن لا بأس انه تستخدمه اذا لقيت. انا عندي هواي حالات تجيني هم شباب ونلقى عندهم التروبونين raised على ساعة يجون للمستشفى with sudden severe chest pain و shortness of breath و ECG changes والتروبونين raised. زين احنا التروبونين raised قلنا وين؟ هو بالاسكيميك هارت ديزيز indicate myocardial infarction بالنونستمي والاستمي. لكن لما تجي هو يونغ تسوي له سي تي كورونري انجيو ما تلقى عنده evidence of coronary artery disease. فشنو الاكسبلانيشن مالتها هي هاي؟ مايوكاردايتس. فالتروبونين هو indicator of myocardial necrosis سواء كان مايوكاردايتس، سواء كان infective myocarditis، سواء كان rheumatic myocarditis، سواء كان myocardial necrosis due to ischemic heart disease.
تمام، عشتيتكم دكتور. بس بقى الاي سي جي دكتور، احنا مو كلش يعني حتى بالمحاضرة الاولى اللي كان بها اي سي جي يعني مو
والاي سي جي هذا
يعني احنا معلوماتنا مو قوية، اقصد عليه انه شلون يعني
الاي سي جي يكون تاخذون محاضرة كاملة به، اعتقد تاخذوها بالعملي.
دكتور احنا خلصنا السيشنات العملي ما كان بها اي سي جي.
اي يعني شوف دكتور فؤاد هو اكو موجود بالكوريكولم مالتكم الاي سي جي، او تاخذوه بالسادس او هسه او شو وقت ما اعرف. اي
تمام دكتور. زين اذا اكو فايندينج بالمحاضرات النظري مال الاي سي جي يعني احنا ما ماخذيه كموضوع شوي صعوبة.
عادة هو الاي سي جي يعني عادة الاي سي احنا الفايندينج هي كمحاضرات نظري اوكي، لكن كموضوع اي سي جي ما يجي بالامتحان.
نعم.
اي اذا تحبون نسوي لكم محاضرة عليه.
والله دكتور افضل، يعني احنا كل شيء عن معلوماتنا عنه في المرة.
ماشي، نشوف اذا صار مجال نسوي لكم محاضرة عليه. احنا هسه خلصنا تقريبا مواضيع الكارديولوجي.
يعني تمام دكتور، بعد ما عندنا موضوع.
بعد ما عندنا بالكارديولوجي موضوع.
تمام دكتور، اذا تقدرون نسوي محاضرة على الاي سي جي ولا نزحمكم؟
ان شاء الله.
ان شاء الله.
اعتقد هو انا راح ابلغ دكتور فؤاد شو وقت افرغ ابلغه. الاسبوع اللي يجي ما اعتقد انا راح اجيكم.
تمام ان شاء الله دكتور.
ماشي.
شكرا جزيلا، تعبناكم.
جزيلا. هلا.